So thank you everybody for joining in the next edition of Oncology Beyond the Obvious. Today we have taken the article from New England Journal of Medicine, October 2024, that is last month. And it is on nivolumab plus AVD in advanced stage classical Hodgkin's lymphoma. As you know, in Oncology Beyond the Obvious, we want to dissect out one single publication and see what is its importance, what is its relevance, what are the pros and cons, and whether it is ready for prime time in the real world as far as India is concerned and the SAARC region is concerned. So typically we have one person being interviewed, one expert being interviewed first, and then another expert does the panel discussion. Today the interviewee was supposed to be Dr. Reena Nair. Unfortunately, her mother passed away this morning. So we convey our best wishes and condolences to her and hope that she has the strength to bear this irreparable loss. And since this happened early this morning, we had to, frantically scramble for a person, an expert who could be interviewed. And very graciously, my dear friend Dr. Hemant Malhotra agreed at the very last minute to be part of this. So indeed, we are grateful to him. Hemant and I are working together at Mahatma Gandhi Medical College Hospital in Jaipur right now. And I have seen how he works really diligently. And there are a couple of features that I think I should, share with you rather than, go through the usual CV. One is that for him, for each and every patient, it is the patient interest that comes first. And he gives a very clear picture to the patient and family as to what the situation is. And I think that is something that is well respected by the patients as well as colleagues, as well as the seniors. The second thing is that when he is teaching his students, I think he really makes sure that the academic program is uh, up to the world class. And because of his dedication and hard work, as well as the dedication of other colleagues from Mahatma Gandhi Medical College Hospital, the institution has received an A plus from NAC, and I think that is a great achievement that Hemant has done. Being director of the Sri Ram Cancer Center, he has a great responsibility both for patients and for administration. And I'm proud to say that I've seen him, do wonders on a daily basis. So with that, I'm also delighted to introduce my co-director for Oncology Beyond the Obvious, Dr. Amish Vora. And he is, one of the pioneers. He's treading his own path. He's taken Hope Cancer Center to greater heights. And I'm sure that in the future, we will see how he develops that into a much larger footprint across the NCR region. So without wasting much time, I now hand over to Dr. Amish Vora to start the interview with Dr. Hemant Malhotra, after, of course, showing the preliminary slides from the publication. So, Amish, over to you.
Thank you, sir. Thank you so much. And while can I have my first slide? And I wanted to thank Hemant sir also, in addition to Parik sir, that in such a short time, sir agreed to be interviewed. Sir, thank you so much. And as always, honored to always learn from you and your wisdom and your experience, sir. Everything. In hematological malignancies, especially once a month or once in 2 months, I do call Hemant sir कि sir ये थोड़ा पंगा है patient का जरा बताओ क्या करना है करके, and he is always eager to help me out. With that, I start today's discussion. So, as a customary thing, I'm going to present few slides about the topic what we are discussing today. So today, as Parik sir said, Nivo plus AVD in advanced Hodgkin's lymphoma. Next slide, please, is what we are going to discuss. And this is October 17th, 2024 paper. And the primary first author is Dr. Herrera. And if you open the YouTube, the entire YouTube in last 2 months is full of his videos because the world believes that this is sort of a class apart publication in itself for multiple reasons. Will come about that. Next slide, please. So patients above 12 years of age were included in this trial. They were supposed to be diagnosed with Hodgkin's lymphoma, and that also stage 3 and stage 4. No autoimmune disorders were allowed. Pulmonary uncontrolled comorbidity also was not allowed. Or if the patient has grade 2 and above neuropathy, they were excluded from this trial. Three of the authors had to mandatory review the block to confirm the diagnosis of Hodgkin's lymphoma. That was one of the requirement of inclusion criteria. Next slide, please. There were 994 patients were registered and underwent randomization. And in the end, if you see, scroll at the bottom of the table, 482 in one arm and 476 in another arm were included for the safety analysis. There was a randomization of 1:1 between the Nivo AVD arm and BV AVD arm. So what it means is that one experimental arm was nivolumab plus AVD, and the other control arm was brentuximab vedotin plus AVD. Next slide, please. Now, this is important. The median age, though, was 27 or in both the arms. But if you see more than 60 years, there were 48 in nivolumab arm and 47 in BV arm, which were randomized. All the patients were stage 3 and stage 4. Around 60% of the patients had B symptoms present. Bulky disease was present in approximately around 30% of the patients, and IPI was done in all patients. 0 to 3 was approximately 70%, and 4 to 7 was 30%. Next slide, please. This was the, again, there are three main highlights. One is they had assumed that if there is a difference of 6% between the control arm and the experimental arm, they have reached the statistical significance. So this trial achieved its statistical significance in 1 year of follow-up itself. But to see the durability of the response, they went up to 2 years of follow-up, and then at the end of 2 years, what they showed that the primary endpoint, which was progression-free survival, this was 92% in the Nivo plus AVD arm versus 83% in the brentuximab vedotin plus AVD arm. If any of you remember Echelon 1 study, and I'm sure Dr. Ashish will present in his moderation in his panel, this is exactly what was the BV plus AVD did in Echelon 1 trial. So there was a reproducible results in BV plus AVD arm, and there was almost 10% difference between the two arm in PFS at the end of 2 years. And this is very interesting. If all of you see the curve, both the curves tend to flatten out as more and more the follow-up comes. That means there are not many relapses. Of course, overall survival at the end of 2 years in Hodgkin's lymphoma, you don't assume it to be different, but 99% and 98%. Next slide, please. In terms of the pre-specified randomization, if you see all the four, age, IPI score, of course stage 3 and 4 was addition, and symptomatic B or A symptoms, everything was in favor of Nivo plus AVD. What we call this as a clean sweep forest plot chart, where everything is to the left, that is in favor of Nivo plus AVD. Next slide, please. What we also always are interested in looking at the side effect profile, and we will discuss that in detail. But in this table, when I see, except for peripheral sensory neuropathy, which was much high in BV arm, which we know that one of the side effects of brentuximab is that everything else was similar. In fact, I was surprised that SGPT elevation, hypothyroidism, IRAs would be higher, but it was not seen to be higher in Nivo plus AVD arm. Next slide, please. And this is, next slide, please. No, previous slide. Okay, so next slide. Okay, stop here. Okay, so this is a few salient features. First time, 10% of patients were above 60 years of age in a randomized fashion. Second, there's a collaborative group effort, pediatric, adult, under the banner of SWGOG. They came together and they finished the enrollment 1 year ahead of schedule. Another salient feature which I'm going to ask Hemant sir very soon is PET-CT was done only at baseline and at the end of all treatment, something which we don't do in routine practice. And the hazard ratio of 0.45 at the end of 1 year and 2 year, I didn't expect when I started reading this paper. And the most important part, I believe this is a watershed event, is that less than 1% of patients received RT. Again, a welcome finding in very young patients. With this, we can close the presentation. And again, it would be my honor to interview Hemant sir. Sir, again, welcome.
So
With
thank
your
you,
permission,
Purvesh. Can I say a few
asking you
things?
questions,
I
sir.
think Purvesh has been very more than kind in introducing me, and I don't think all those things are true, but I will try to do the best I can for this. And I feel in very big shoes. Dr. Reena Nair is a very dear friend of mine, and I'm very sorry to hear about her loss. And this is like a paper which I think is very important. And congratulations and thanks to the Oncology Beyond Obvious team for choosing this paper. And one more important thing is that both the interventions and all the drugs which are used in this paper are available to us in India. So it has actually relevance to us for the next patient we see in our clinics. So very appropriately chosen paper. Didn't have too much time to go into word by word all the appendices of the same, but I will try to do my best. Back to you, Amish.
Thank you, sir. Sir, for you, with such a vast experience of treating Hodgkin's lymphoma, I think half an hour of reading also is more than enough for us to learn from you. I will start asking you questions. The first four questions, I would request you just to answer yes or no. And then if you want to elaborate why you have said yes and no later on, but I just want yes or no for first four questions, sir. One, sir, we have plethora of regimens available before brentuximab vedotin: MOP, COP, COP ABV, Stanford 5, escalated BCOP, modified BCOP, ABVD. If I understand correctly, all are equally efficacious except one paper of Stanford 5 which was there. We choose ABVD purely because it is less toxic. Sir, yes or no?
I think it is more effective than MOP and COP. That has been pretty much proven. So the answer is no, because it is more effective and less toxic. So both things are
Okay,
there.
right, sir. So your answer is no to the first, that ABVD is still more effective than few of the regimens. Fair enough. Brentuximab vedotin, based on Echelon study, is better than ABVD without question. Yes or no?
Yes.
Perfect. Nivo AVD is better than brentuximab AVD. Yes or no, sir?
Yes.
Perfect. And the last question, sir, Nivo AVD, although not directly compared, but it is better than ABVD, sir. Yes or no?
Possibly yes. So if A is greater than B and B is greater than C, then
A is greater than
A
C.
should be greater than C also. No, but
Perfect. Thank you.
again, as we, keep reminding ourselves again and again, cross-trial comparisons are fraught with their own handicaps and dangers, and not an advocated practice. But I think it would be reasonable to assume, and I would answer that as a yes.
Yes, perfect. Right, sir. The first question which I wanted to ask you, sir, there was 2021, there was a network meta-analysis of from 1995 till 2021. And what they found was, Stanford 5 compared to ABVD was the only regimen which is statistically significant in terms of the efficacy. And that's why I thought of asking you. I always believed since my DM days that we are choosing ABVD because it is less toxic. Otherwise, there are many equally efficacious regimen. But that is what I wanted to clarify. But you, as you rightly said, there are ABVDs better than few other regimens also. So let's come to this paper, which I mandatorily ask to all the people who we interview. Do you think this is a practice changing paper, sir? First, let's start with yes, no.
Yes, I would think so. Yes.
Perfect, sir. So 2 years of PFS. I mean, basically, the primary endpoints was PFS and 2 years of PFS in a disease like Hodgkin's lymphoma. Is it worth that it will translate into long-term PFS and long-term OS, or we have to wait for the longer follow?
So it is very possible that this will continue and translate into 5-year and 10-year benefit with both the PFS and possibly also the OS. And something which is reassuring for me, two things. The first is that the delta at the
So can I
1 year,
request you to speak a little louder,
yeah.
sir?
So the two things which are reassuring for me and support, my uh, the yes answer. The number one is that the delta at 1 year, the PFS delta at 1 year and the PFS delta at 2 years is not decreasing. It is about the same or increasing, 8 at 1 year and 9 at 2 years. And worse come to worse, if the cars do come together, we still have a equi-efficacious regime, which is significantly less toxic than the BV-AVD regime. Can be given in children and can be given in elderly patients. So that is a big enough advantage for me to, emphatically say that we are looking at a practice-changing regime and a practice-changing paper.
Done, sir. Sir, it was very interesting. I asked you this question because if we see Echelon 1 trial, which has now 6 and 7 years of follow-up, at the end of 2 years, the PFS with BV-AVD was 83%. And at the end of 6.5 years, it was exactly 83%. What I wanted to ask you, just addition to this question, in your clinical practice, sir, do you see late relapses in Hodgkin's lymphoma, those who have not relapsed till 2 years of time? Do you see them relapsing later on?
Yes, it does happen. So that is why in a disease like Hodgkin's, you have to kind of look at the 5 years and the 10 years also data. And unless you have 5 years, 10 years data, I mean, you cannot with confidence tell the patient, okay, you're out of the woods now. So late relapses do happen.
Okay, agreed, sir. So the next question will be 83% was assumed based on Aquilon 1 trial that BV plus AVD arm will achieve. And they have said minimum 6% improvement, that is up to 90% EFS in Nivo plus AVD arm should be there. Where is this, where do you think, sir, this 6% or 7% came from? Or you think that the authors were right to assume that Nivo AVD definitely would be better than BV?
So there is some preliminary data of, efficacy, maybe more than preliminary data of efficacy of checkpoint inhibitors in Hodgkin's disease. And in the second line setting, this has been both Nivo and Pembro have been found to be very effective. And we may also want to highlight that the malignant cells in Hodgkin's disease, the Reed-Steinberg cell, almost 100% of these cells express the PDL1 receptor. So theoretically, PDL1 blockage is supposed to benefit. And there is a significant amount of evidence accumulated in second line trials and also small single arm first line trials that checkpoint inhibitors in combination with chemotherapy are effective and equi-effective or more effective than the brentuximab plus chemotherapy combinations. So I think they chose well, and of course, in hindsight, it was proven that they did choose well.
The trial design, I'll ask you two questions about the trial. One, in adults, 240 mg nivolumab was non-negotiable. Less than 18 years, they said, okay, you can go up to 3 mg per kg. But in adults above 18 years, 240 was non-negotiable. 3 mg per kilogram is something what we have been using in solid tumors versus 240, and we have found them to be equivalent. Do you think, sir, that in India, if we change our practice, say a 50-year-old adult, 150 mg of nivolumab versus 240, we will save a lot of money?
Yes, theoretically, yes, but it is always what should I say, a dangerous practice to mess around with the doses which have been proven to be effective. Unfortunately, we never have any treatment which is 100% effective. And if you use reduced doses, then you're never sure that the lack of response, either it is because the disease is resistant to your regime or it is because of the lower dose which you've used. So you have to have a, clinical trial in place, or you have to have a, completely convinced patient and the patient's family to be able to do this. So I'm actually a little conservative on that front, but that is what I feel, that if X combination is producing a response, then X minus A, whether that lack of response is because of the inherent small percentage of patients who will not respond, or it is because of lower dose, we don't get to know. And the patient and the family also feels ki possibly the lack of response is because the doc used suboptimal dose. So we have to be, think about all fronts on this.
So your take home message is no matter whatever may be the disease, if the clinical trial, randomized phase 3 clinical trial, which is a registrational trial also, whatever dose they have used in practice, we should stick to that dose. Right, sir?
Yeah, if there are no reimbursement issues, if you have an affording patient, that's what I think you should do.
That's what you should
And
do.
I mean,
I
we
think
are
that is a
also,
very important message to take home.
yeah.
Second point in the trial design, sir, interim PET scan. Now, this is my practice changing thing. In no Hodgkin's lymphoma ever, we have not done PET CT till the end of the disease. What do you think of this, sir?
Yeah, actually, it is something which is maybe we can call it not standard of care, because it is pretty much established since a relatively long time that interim PET does help you in decision making. And I wonder why they did not do the interim PET in this particular study. And in the discussion and in the limitations, they have discussed some limitations of the study. They haven't mentioned this point at all. But the off-study discussions, this point has been raised. But I just wonder if patients had a suboptimal response in the post-2 cycle interim PET CT, then what would they do in the trial? Would they change to the other regime? Would they take the patient off the study? You already are presuming a response rate of 90%. So like the margin of error is pretty small. So I guess that must be the factor why they did not include the interim PET CT in this study.
Dr. Ashish has, sort of, he's going to cover about what is the reason, but what I had understood, because in rectal cancer in dostarlimab study, what people have found that you should not do the PET scan earlier. Immunotherapy takes little time for it, so what they found that you should do PET CT only at the end of 6 months. Only then you will really come to know. This may be one of the reason by which the authors have decided, but I felt that this is not fair for BV plus AVD arm, at least in our practice. So what do you do? What would you do? And you already told me that you will stick to the protocol what is there. In your clinical practice tomorrow, if Nivo plus AVD patient comes, are you going to do PET CT only at the end, or are you going to be symptom based? What are you going to do in your practice, sir?
So I will probably not do the interim PET CT because I don't have a regime which is better than this regime. And number two, the point which you made, which I should have made also earlier when I was answering your question, that in the initial few cycles, maybe after 2 cycles, you have the checkpoint inhibitors gathering all the immune cells at the disease site and doing a activity test or a metabolic test, like a PET CT scan will invariably show, or in many cases show increased FDG uptake at the disease site, and then you will not know that this is no response or progressive disease. So that is one of the reasons why with checkpoint inhibitors, you have the IRS, which you have to do rather than the RESIS, which we typically use.
So in your practice, sir, you would stick to the protocol and do the PET CT only at the end. Okay,
Yes.
I take your point, sir. So this is the first time probably, again, we'll have to go to the details of literature, but first time 10% of patients enrolled were 60 years and above. My specific question to you, sir, would be because you have been, involved in clinical trial in both all the three ways. Uh, do you think this is level one evidence? If you do the subset analysis of 60 and above, which they have done, is this level one evidence for me to change my practice tomorrow in elderly Hodgkin's lymphoma?
Maybe it is not level one evidence. You will probably need another larger study, but there were more than or close to 50 patients in both the arms, and the analysis was it was a pre-specified subgroup.
Correct.
It wasn't a retrospective analysis. So I think that is pretty good evidence, and the toxicity profile and the response in 60 plus, where we always struggle, particularly if the patient has a stage 3, stage 4 Hodgkin's. If the patient like that comes to me tomorrow, then I would have no hesitation in giving this regime to that patient. And I think one more really unique aspect of this study was that it was a purely academic study. It was not a
Correct.
industry-driven study. So which gives us who read the study or who take home messages from the study that there is this evidence is really solid. This was conducted by an academic organization, the SWOG, and the COG Children's Oncology Group. And one more important thing was they included some adolescent and young adults in this study. Usually, most of the studies which we see, inclusion criteria is 18 to 60. So they did 12 to 18 also, and they did more than 60 also. And in this one shot, they gave us an indication that this can be used in TYA population, and this regime can also be used with effect with significant less toxicity in the 60 plus age group. So like a pretty smart study, yes.
I completely agree. That was going to be my second question, but you have already answered that. So I will not delve into that. Sir, I will still like to ask you about category one. As you rightly said, I'd like to go into that. Sir, if we look at the modified brentuximab and BCOB, if you combine that BRACAP, the inferior outcome was there in elderly patients. If you look at ABVD minus bleomycin, we have paper after paper where there is an inferior outcome. This is the first time in a randomized control fashion, 10% of the patients are in elderly age group, and they have found Neo-AVD to be far superior to any other known regimen to mankind and tolerable. Why wouldn't I call it as a level 1 evidence, sir? And I would change my practice tomorrow itself. Any elderly patient, if they can afford, they are this Neo-AVD is the regimen to go to.
I agree with you that I would be the first person to use this regime for my next patient of 65-year-old Hodgkin's, advanced Hodgkin stage 3, stage 4. But I'm not sure whether this will qualify as level 1 evidence.
Got it, sir. So basically, on paper, by definition, it is not level 1, but in your practice, you are convinced that this will be the first regimen you will think of in elderly.
Yes.
Right, perfect. So that is what I completely agree with you. So second important landmark, and this would be my second last question to you would be, of course, third last is the customary, uh, radiotherapy. As you rightly said, sir, 12 to 18 years children and adolescents also were included. And we know that in a stage 4 Hodgkin's lymphoma, close to 35 to 40% of the patients, they get radiotherapy at the end of the study. We all do that. Here, less than 1%, sir. In fact, in both the arms, it was less than 1%. Are we looking at changing our pediatric oncology practice here, sir? And is this the most, according to me, this is a very, very welcome, fabulous news to me.
I think I completely agree with you, Amish. This is a really important finding in this study that you can do away with involved field or involved nodal radiotherapy in the TYA population. And you know that if you radiate these people, then you really produce, ghastly skeletal effects. I still have patients who come to me, big, healthy people, but with such thin, scrawny necks that whenever I see them, when they've received radiation to the cervical area, whenever I see them, I feel horrified that why did I do this? And if we, and less than 1% versus almost 1/3 of the patients, being required to receive radiotherapy, I think this is a very important take from this study.
Right, sir. Sir, my second last question to you would be, if you look at the toxicity, if you look at the discontinuation, if you look at the death, Nevo AVD scores over BV AVD. Like SWOG study, this paper is an academic paper. Sir, OBTO also is an academic, and I would like you as an academician. Is this the death knell of brentuximab vedotin in the first line in Hodgkin's lymphoma, sir?
That's a very provocative question. You will still will have some patients in whom there is a contraindication to the
Absolutely.
use of checkpoint inhibitors, where you would use a BV upfront. And there is a remote outside possibility that the 5-year results and the 10-year results are startling, which is a small possibility, but we do have to keep that in mind. And my belief is that in addition to ABVD, in quick succession, in 5 years, in a 5-year period, we now have two excellent regimes. ABVD still will remain the poor man's choice for Hodgkin's disease, particularly in the early stage. Also for non-affording patients, both BV and Nivo in our country are extremely expensive, so it will still have a big place, just plain ABVD. And I'm sure that there will be a niche for BV, AVD also, but possibly the preferred first line regime for most populations who do not have a contraindication to a checkpoint inhibitor would be a Nivo AVD.
Agreed. So, my last point is, if I understand correctly, Dr. Hemant Malhotra agrees that in absence of OS data, with the PFS data of 2 years, patients from 12 years to say 70, 75 years of age group, those who can afford and are eligible for Nevo AVD in stage 3 and 4 Hodgkin's lymphoma, Nevo AVD is the regimen to go to. If you agree, sir, or if you want to have any additional comments, you can give. And after that, I pass over to Dr. Parekh, sir.
So I agree with your summation and my thought process. And even if after 5 years, both the regimes, the PFS and the OS, turns out to be equal, we still have a non-inferior regime to the BV regime, which is much less toxic. The dose reductions, dose interruptions, dose cessations is much less. So I would, without hesitation, commit myself to saying that this would be the regime to go to for most patients.
Thank you so much, sir, for your wisdom. And sir, you stay over. Again, you are one of the panelists also, sir. We want to learn more from you. And over to Parekh, sir.
Thank you very much, Amish. Thank you very much, Dr. Hemant Malhotra. I think that was a good in-depth analysis of what the publication is. And it seems to be so attractive for the in the Indian context because the patient's quality of life will be much better without compromising on the outcome. Now it is my honor and pleasure to invite Dr. Ashish Bakshi to be the moderator for the panel discussion. Ashish is a very dear friend. We were together at Tata Memorial Hospital, and then he has, formed a niche for himself, both in the Thane area as well as in the Navi Mumbai area. He is a medical oncologist par excellence, but really very interesting is that he has not left his keen interest and knowledge and insights into the hematology oncology aspects as well. So Ashish, thank you very much for agreeing to be the moderator today, as well as being the hematology track director for the 51st ICON conference, which is happening from 29th November to 1st December. His panelists are also equally prominent medical oncologists and hemato-oncologists from different parts of our country. They include Dr. Sainath B, Dr. N. Aditya Murli, Dr. Prashant Mehta, Dr. Tejeshwar, Dr. Akash Jha, Dr. Ranjit Kumar CS, and of course, Dr. Aman Malhotra. So, Ashish, over to you to initiate the panel discussion. And once more, thank you very much to you as well as all the panelists.
Thank you very much, sir. So I'm starting to share my screen. So can you see the presentation?
Yes, sir.
Oh, all right. So, so before I begin my panel discussion, I just want you to forget the discussion that Amish just had with Hemant Malhotra sir and make an unbiased opinion about the next graph that I'm going to show you. So these are two graphs actually that you can see on your screen, and just make your impression. So I'm going to ask all the panelists one by one. You have one graph on your left hand side, one on your right hand side. What is which one looks better to you, graph A or graph B? So maybe Dr. Aditya Murli, you can start.
Thanks, Dr. Ashish. I think first rule which everybody has taught me is never interpret a graph without having any blackened out data. So, to be fair, sir, I would want to know some more about what is better, because I'm not sure if this is enough reason to pick one over the other.
Absolutely. I just want a prima facie impression. I agree with that. We are going to dissect that actually.
Prima facie A might be better than B.
All right. Prashant? Is Prashant there?
Sir is not
Sainath?
logged in yet.
Achha, Sainath?
Yeah, I think A looks better than B, but one has to see that the months it's just stretched out. I think B is just more stretched out than the A. If you have to see, this is the follow-up is the follow-up probably is at 48 months. Here it is up to 60 months. But like I said, we always need to put things in context and then only interpret.
Okay, Dr. Tejeshwar and Dr. Akash, quickly.
A looks better than B.
All right. Akash?
Obviously, the difference seems better in this, but it is very hard to make out. But if you see the upper graph, it is better in B, basically.
All right. And Ranjit?
Yeah, looks A is fairly better because we have a long-term follow-up, I think so, than B.
All right. Okay. So we'll come back to this. I think Hemant sir has already known the data, and of course others have also known it. So we'll try to dissect actually this.
So Ashish, can I make a point?
Yes, sir.
So in the study which we are discussing, I think which is the top left panel, right? PFS. There, as soon as you stop the treatment, like there is a sudden dip in the red curve, right? And there is a smooth, progression of the blue curve. So this, I think, indicates to us the prolonged, sustained benefit of checkpoint inhibitors and the tail which we talk about in other solid tumors, right? You see that sudden dip after 6 months in the BV curve.
Yes, that's right, sir. So anyway, let's move on.
Ashish, Amish here.
Yeah.
This may also look like breast cancer CDK4/6 inhibitor ka curves, yaar.
All right. So anyway, Amish has already told this study. I can't move this thing. So anyway, I'll move from here. So Amish has already briefed the study, the nivolumab AVD in advanced classic Hodgkin's lymphoma. Now, just to quickly recapitulate, this was a multi-center randomized open label phase 3 trial. The enrollment started in 2019 and it finished in 2022. And there were 2 arms which were randomized to nivolumab AVD followed by for 6 cycles, and the other arm received BV AVD for 6 cycles. And what is important for all the people who are listening is that in terms of the sequence of administration, AVD is to be given first, followed by nivolumab, or in the BV AVD arm, AVD is to be given first, followed by brentuximab. This is one practical point which everyone should remember. In the trial, it was mandatory for the BV AVD arm to receive GCSF because of the high risk of neutropenia, whereas in the nivolumab AVD arm, it was optional to use the GCSF. So it was at the investigator's discretion. This again consort diagram Amisha has already shown. Important thing to note here is that treatment discontinuation was slightly more in the BV AVD arm. So about 12% of the patients discontinued treatment as compared to 7.6% in the nivolumab AVD arm. Now, most of the patients were actually, so 2/3 of the patients were actually in the age group of 18 to 60 years of age. But as previously discussed, there were patients who were more than 60 years and those with young adolescent between 12 to 18 years of age. One slight imbalance is that bulky disease was slightly more in the nivolumab AVD arm as compared to the brentuximab AVD arm. Now, you have seen this. So the progression-free survival was better with nivolumab AVD as compared to BV AVD, 92 versus 83% at 2 years. And if you look at the forest plots, the across the board, irrespective of the age of the patient, the IPS score group, the stage of the patient, whether it was stage 3 or 4, or whether they had B group symptoms or not, the outcomes were better with nivolumab AVD as compared to BV. And of course, as Amish mentioned, there was no difference in overall survival. So quickly, a word from all of you. What is your impression about the trial results? A, out of the world results, it can't get any better. B is impressive. C is would like to wait for more maturity. And fourth is they are okay. So maybe one by one, quickly, all of you can answer this.
So I think I would say B, hopeful that it will become A in a couple of years.
All right. Others, please quickly.
So my opinion is it is an impressive results, but results can be in the future also, there are future studies can come that will make better outcomes also.
Okay, Dr. Akash?
I think it's
I feel it is close to out of the world results. It won't get better than this. And any new drug, I don't know if it happens, it can increase the survival from 98% to more than that world survival. So it's very tough to say, but it is close to the best.
Okay, all right. And Sainath?
I think these are impressive results. It can get better because we still don't have the OS data to make final conclusions. So we are in for surprises as well. But this is an impressive result. I mean, having a 10% additional PFS benefit, it's nothing short of it.
Okay, and Ranjit?
Yeah, it's impressive, definitely, because we have seen with the ABBD, just simple ABBD, with the PFS around like 70%, and now we are reaching up to 93%. Probably we just need to see until 5 years, because for any cancers, we always say like wait until another 5 years data to mature, and probably we will see.
All right. I think Hemant sir, I'm going to come to you in the later part because we have already heard your views. So let's start dissecting it. Now, for all the panelists, are you happy with the trial design, conduct, or monitoring? Are there any issues that you feel are there as part of the planning of the trial or conduct of the trial?
So in terms of the design, as good as we can get, Dr. Hemant did say this, and I would also want to stress upon this, that not doing interim PET is more of an insecurity for the treating doctor than actually in terms of a trial design, because earlier we did the interim PET primarily to see if we could escalate therapy, but in this kind of a trial design, there is really nothing much that you can escalate in terms of escalating therapy. So if you really want to nitpick, it would be lack of having a interim PET.
All right. Does anybody want to add to this perspective?
Probably we all know that because even the low dose of nivolumab trials, if you see, most of the trials has shown that nivo will take much longer time for having a response. So that could be one reason. The second reason probably, like if you see,
So there is an phase 2 data, I think, with before going to the phase 3 data, they have done a phase 2 studies. I think in the phase 2 studies, in the interim PET, they saw very high rates of PET positivity, around 50% like that. But still at the end, those patients still perform better. I think that is the reason why they have omitted interim PET here.
All right. Any other issues in terms of the trial design?
Another thing which is slightly okay, it's not a trial design, but something with the trial which is slightly surprising is that 30% of the patients in the Nivo arm at least had bulky disease. Now, in clinical practice, if we have some patients with bulky disease, how many times would we say only 1% of the patient with bulky disease would we really go and do a radiation? So, at least in my own practice, if I have a bulky disease at presentation, I would still want to discuss the radiation option, no matter how good the PET scan looks at the end of treatment. So maybe that's another thing out for a clinical question.
All right. Okay.
But
So
I think even the irradiated bulky disease has also been changing over in Hodgkin's lymphoma, especially in the advanced stage of Hodgkin's lymphoma. In early stage, I do agree that bulky disease probably because you are shortening your consolidate with T. But in advanced disease, I think is significantly decreasing your.
All right.
I think it's a very significant thing, and I feel we have to take it as positive. Despite that, the PFS has been maintained. So I think that's an important key point here.
Okay. I'll just add one small comment here. It does seem that PET2 is prognostic, but now you can't complain when you are getting these results. So we have been conditioned to do PET2, but after this data, this reassuring data of 90s PFS, maybe what we were doing is not necessary now. So we can't complain about this. It's just the way of thinking. And obviously they must have done it because of the issues with immunotherapy response evaluation. So we can't complain because eventually they are not relapsing at 2 years.
All right.
Seems fine.
All right. So I had one issue with the trial design, and I want to know your opinion. Would BRICAD would have been a better regimen to compare with Nivo AVD versus BRICAD?
Ashish, I'd like to say something here.
Yes, sir.
I think if this was not an academic trial and if this was an industry-sponsored trial, suppose BMS was to do this trial, what they would have done was that they would have kept ABVD as the comparator arm, right? Because it was a purely academic trial, they answered a really vital questions for practitioners like you and me, that this is the standard of care now, BV plus AVD, and let's compare this with this new regime. So we're really happy about that this was an academic trial and not an industry supported trial, and they asked a question and answered a question for which we wanted an answer.
I think your point of using BRICAD as a comparator arm, two things in practical point of.
Go ahead. Yes, I
definitely afford nivolumab. That's an important. And if the patient is affording brentuximab, he can also afford nivolumab. The second point is if this trial has shown that Nivo AVD is better than brentuximab AVD, even if I assume that BRICAD would be in a better comparison, I would give less chemo, especially to my patient when the patient has an affordability to take Nivo rather than giving a BRICAD. So thereby also there is a factor of decreasing the toxicity. So in that way, I think it's fair.
All right. So actually the HD21 trial, this compared actually 2 cycles of BCOP with 2 cycles of BRICAD. And this was the interim PET adapted therapy where those patients who were PET negative after 2 cycles, they received another 2 cycles of either escalated BCOP or BRICAD, and or otherwise those who were PET positive were randomized to 4 cycles of BCOP versus BRICAD. And what this trial showed was that this was the two curves that I showed you initially. And yes, you wanted to see the data. So here is the data actually. At 4 years of follow-up, actually, BRICAD, when compared with escalated BCOP at 48 months, the progression-free survival is 94.3%, as compared to 92% what we are seeing with nivolumab AVD at 2 years. So this looks slightly better actually. With a longer follow-up also, this looks slightly better as compared to the nivolumab AVD. So your comments now. What does anybody want to have comment on this?
Probably this actually like the BRICAD one, as Sainath says, probably it has a more toxicity profile. So probably like now with these results, majority of us probably we choose the Nivo with AVD. That's point number 1. Point number 2, probably like based upon the Echelon trial, we have a clear-cut data ABVD versus BVAVD. So it has been proven that the BVAVD is superior to that of the ABVD. That point we know that. Now, if at all like they need to compare, so they need to have another like drug which is we are routinely using. So that could be an immune checkpoint inhibitor. So that's why like probably like the trial comparison would be appropriate and academically. And based upon this cause, I think like purely based upon the toxicity, I think yeah, maybe like Nivo AVD would be better.
So forget the toxicity part. We are going to discuss the toxicity later on, but purely merits on the progression-free survival benefit. Yeah. Do you feel that BRICAD is better than nivolumab AVD?
It may not be a better because it may be a non-inferior trial. Probably if you conduct.
Of course, this is a cross-trial comparison, so obviously it's fraught with the issues.
There are going to be significantly different in the population side, population's baseline characters between the Nivo AVD and the BRCAD. So it is very difficult to compare these two studies. And probably the toxicity profile also, if you see, BRCAD is like discontinuation rates in BRCAD are somewhat higher when compared to the Nivo AVD. So unless Nivo AVD is compared with BRCAD, we cannot make a conclusion that this is going to be better or this is going to be better, because they're both are somewhat different populations.
All right.
So just to add one point, if you see the Echelon 1 trial, the BCOP arm, escalated BCOP arm is doing the same exactly what it is doing in this Nivo AVD trial. The patient population is, the representation is almost same, Echelon 1 and Nivo AVD trial. So the efficacy seems better in this HD21, and it is very hard to compare these two trials just by plots. All we can say right now is it is very hard to say BRICAD will be better than Nivo AVD. Maybe it will be equal around, but maybe on toxicity basis, Nivo AVD wins, and as well as the age gap, the groups that it has. It has included. Right. That is the biggest advantage of, and then the radiation is very, very important. That was done in more patients in BRICAD and this SD21 in comparison to Nivo AVD, where only 1% was done. So that is a big win.
And adult patients are like more than 60 years also are 10% represented in the Nivo AVD, which is slightly similar to the real world scenario.
So also if somebody is interested, the hazard for this is 0.6. The other side, the hazard is 0.4. So where do we, how do we compare that? This is a straightforward targeted versus chemo comparison.
I just want to make.
Yeah.
So I just put it in a different perspective. So if you use your conventional ABVD, your PFS is for the tune of 70-75%. So it is that who are the additional 25% bad performances. So around 10 to 15% of are these early relapsers and refractory disease ones. These are the ones which are problematic. And the rest of the late relapses, 10 to 15%, 10% or 15% of them, they can be easily managed by a good salvage regimen. Now, if you look at both the curves of the BRICAD as well as the NAVD arm, NAVD clearly shows your early relapses. The curves start separating just when the treatment finishes. So all your early relapses and your primary refractory disease, the most tough ones, I think NAVD is taking care of it. Now, in comparison to that, the BCOP or the BRICAD traditionally did better in this, primary refractory cases. That's why the separation is probably delayed. The separation goes well beyond. So the late relapses is where probably brentuximab is giving an advantage. So if you see in Hodgkin's, the biggest problem in patients who relapse are the early relapses and the refractory disease. And what, at least by the cross trial comparison, definitely we should not do. But if you look at the curves, I feel probably Nivo AVD does better in the primary refractory and early relapses, the bad subset. So probably Nivo AVD might do better, especially in this subgroup, but we are never going to have a trial like this, especially
But
for this.
actually, with long-term follow-up, also BRICAD is 94%, 48 months actually PFS, and here actually in 2 years itself we are seeing 92%. So numerically speaking, it looks better that BRICAD will have a better outcome as compared to nivolumab AVD.
Difficult. We cannot I don't think we can make that conclusion just by a cross comparison or a percentage or a 2 percentage point. I would have agreed if brentuximab AVD 82 versus BRICAD 94, definitely yes, probably BRICAD does better. But for a 2 percentage point difference, I wouldn't make that strong conclusion.
All right. Anyway, we have a lot of things to discuss, so let's move on. Just one quick question to Hemant sir. Sir, actually, corticosteroids were permitted as a part of chemotherapy pre-medication in this trial. And typically with immunotherapy, we avoid actually steroids along with the immunotherapy. So what would you do? Would you give steroids or you will not give steroids the pre-medication?
So I think if you're using a good anti-emetic regime, which will control the early and the late nausea vomiting without steroids, then like Akenzio or the similar combinations, then I think you can omit the steroids. And my personal feeling is that this absolute no-no between steroids and immunotherapy, my personal feeling is that this is a little bit of overhype. And as we get to, be more familiar with immunotherapy, we learn more about immunotherapy, we'll realize that it doesn't make too much difference. That is my personal opinion.
All right. Okay. So another issue that I would like to discuss in terms of the conduct of the trial. Does anybody have any objection to the way they monitored the disease scores? Any of the panelists?
I think you're talking about the interim PET.
Not necessarily the interim PET after the treatment is also over. Like the way they kept follow-up of the patient, subsequently doing scans and all that. Are there any issues with that? So anyway, let me come to that. In the detailed protocol, if you look at they did monitoring of the patients up to 10 years of age, but the examination was primarily history and physical examination, quality of life, and of course other issues. But all patients had CT scan of the chest, abdomen, pelvis at 1 and 2 years after the registration. Subsequently, actually, if you look at this table is from the protocol that has been provided with the NEGM itself. If you look at beyond 30 months, 36 months, year 4 to 10, there have been no PET-CT, CT or MRI. So we really do not know that if somebody has really a progression beyond 2 years, there is really no way to know whether how the patient has progressed or not. So how one can conclude really that beyond 2 years, what is really going to happen, whether there are going to be any subsequent relapses with nivolumab AVD. And this is my major objection to the way they followed up with the patient. So again, the enrollment was, as I mentioned, was started in 2019. It finished in 2022. So is progression-free survival an acceptable primary endpoint for all of you? Quickly, a yes or no? Anybody has an objection for PFS being a primary endpoint, or you would like to wait for the overall survival?
Not really. I think in a disease where there are so many post
Aditya, your voice is breaking.
PFS is an acceptable endpoint.
All right. Anybody has a different view?
I agree.
No, I
PFS
agree.
is acceptable.
Yeah,
It's
it's
an
completely
acceptable
acceptable.
All
point
right.
for Hodgkin's.
So actually, if you look at the overall survival benefit, the data has been published in 2022 in NEJM with BV-AVD. Actually, the 6-year survival is 93% with BV-AVD and 89% with ABVD. So actually, the long-term survival benefit has been shown with actually BV-AVD. We do not know really whether there will be a survival benefit with this thing, but this has also come up on a long-term follow-up. So maybe something that we have to look at. Is everyone happy with the median follow-up of 2.1 years? Is it adequate to judge the long-term overall survival? Again, quick yes or no?
No, I think we need longer data to say that there is also overall survival benefit.
All right. So I would like to draw your attention to actually these survival PFS curves that have been published again in the NEJM article itself. I have drawn two parallel lines beyond 12 years of age. If you look at the survival curve, PFS curves of BV-AVD, they're actually parallel to this lower line. Whereas that of Nivo-AVD, although initially it is flat, but actually beyond maybe around somewhere around 18 months of follow-up, it starts going down. And actually, as you can see here, the gap is widening here. So as probably with more and more longer follow-up, whether there will be more events in the Nivo-AVD arm, we do not know. With BV-AVD, actually, from both the trials, if you look at, there has been a consistent a plateauing of the benefit with BV-AVD as compared to the Nivo-AVD that I'm seeing. Why this is important is that if you look at the events that are there beyond 36 months, very few events have happened in the patients in both the arms actually. So it is difficult to say, but as I said, there seems to be a greater dip in the nivolumab AVD arm, whereas there is a nice flattening of the curve in the BV AVD arm. Now, Amish has mentioned in his presentation with BV-AVD, with the 2018 publication, and even after 4 years also, it has been quite a consistent benefit, 82% in at 2-year and 6-year follow. So, which is actually nice flattening that we would like to see. Now, I would like to draw your attention to this phase 2 CheckMate 205 design. This was the precursor study where before they actually conducted this phase 3 trial, where there was the initial run-in of monotherapy with nivolumab for 4 doses, and then patients were given the current regimen of nivolumab with AVD, and again the patients were treated for 6 cycles. Now, if you look at the publications of this study, this was a cohort D, again stage 3-4 patients, and here stage 2 bulky patients were also included. The median PFS rate was 92% at 9 months of follow-up, and in the subsequent publication or presentation, the PFS rate was at 21 months or 83%. So there is then some decline in the phase 2 study from 92% to 83%. So this is a editorial with along with the publication. I'm sure all of you must have read this. Dan Longo and James Armitage has given, and they have given a caution actually. The majority of patients with Hodgkin's lymphoma who relapse do so in the first 2 years after treatment. Unless remissions induced by immune checkpoint blockade plus chemotherapy are different, we do not know that yet, and however, time will tell. So this is a cautionary note that these editors have given. So any comments from any one of you? Like, what do you feel about this data that I just showed you?
Yeah,
I
majority of the
Completely
Hodgkin's.
agree.
Yeah, I totally agree. I think when the title says, can it get any better? The only better is your longer duration of nivolumab after 6 NAVD. I think that would probably answer. I'm not sure, but again, we need to see the trials if they can address the exact point. So that is where I think maybe it can get better, because all the adjuvant in solid tumors, what you have seen is all the adjuvant trials, they have given immunotherapy at least for a year.
Okay. Hemant sir, any comments?
Yeah, I think I agree with the panelists that 2 years is early days, and we still need confirmation of the same results at 5 years and 10 years in a disease like Hodgkin's. But even if the curves were to come together, I would feel that the very fact that you have a regime which is maybe equi-efficacious, words come to words, when it is significantly less toxic, that would, kind of put this above the brentuximab regime.
All right. Okay. So let's
See,
move on.
Amish here,
would,
Amish here.
I would like, yeah, Amish.
So you have presented in the previous slide the 9 months and 21 months in the checkmate study. Okay.
That's right.
So 9 months it was 92 and this was 83 at 21, so it's a drop. But here in the Nevo AVD NEJM publication, they have done at 12 months and they have done at 2 years. And they have found only 2% difference in the PFS. And this is a randomized trial what they have seen. That so my point was that here you have shown that at the end of 2 years also the difference of 9 percentage has been maintained between the BBAVD and this. And in my practice, Hemant sir said that we see late relapses, but up to 2 to 3 years, if those who don't relapse normally, they don't relapse after that. And that's why this 2-year PFS in this Hodgkin's lymphoma study is important according to me. I would be really, really surprised if the delta merge together.
Okay. So
I would
anyway,
like to, I'll just add one small point here. So if you see the subgroup analysis, I mean the supplementary tables, and you see the end of treatment PET post 6 cycles of Nevo AVD as well as BCOP, the PET DB4-5 is still more in the BCOP arm. So it is 22% versus 12%, 12% in Nevo AVD. So I'm not sure if PET positivity in treatment PET positive, which is may lead to more relapses and even BCOP. So it's very tough to say, but yes, waiting for the overall survival. All right, let's move on. Coming to the toxicity, actually, Amish has again highlighted this. Neutropenia was more in the nivolumab AVD arm, but because less patients received GCSF here, sensory neuropathy was, as mentioned, more with BV AVD, and fever, but actually febrile neutropenia was identical in both the arms. And hypothyroidism was obviously as expected with the nivolumab AVD. Hypothyroidism and hyperthyroidism was seen in patients who were 7% and 3%. So yes, of course, some hypothyroidism was noted, but again, like we know that we can expect actually that this would happen. Now, in terms of the toxicity, grade 3 toxicity was neuropathy was seen in just 8% of the patient. Febrile neutropenia, as I mentioned, were quite comparable in these two arms. So grade 3 neuropathy was about 8%, is something important to remember. Now, I would like to draw your attention to the treatment discontinuations that happened actually. If you look at these charts that are given in the appendix, 92% of the patients completed, less patients actually completed the brentuximab AVD. So 4% difference here. However, the discontinuation due to adverse event is 4% versus 4% in both the arms. Secondly, the reasons for discontinuation, refusal unrelated to A in about 3% with BVAVD, other not protocol specified, another 1.7%. So these are actually, it is difficult to understand that why these patients discontinued the BVAVD. But again, as I mentioned, the discontinuations were more with this thing, and more patients continued to receive AVD when the BV was discontinued. So this is something probably might have actually impacted the results. We do not know. Death due to lymphoma was comparable between the two arms, 1% and 2%. If you look at the survival curves, as you know that as of now, there is no difference. In terms of the age of the patient, actually, again, no difference in the younger age group. In the 18 to 60 years of age, death was 1.2% versus 1.3%. So here, no difference. But the major difference comes in actually patients who are more than 60 years of age. In the BV arm, more patients died as compared to the patients in the nivolumab AVD arm. So probably we might start seeing a survival difference over a period of time as we get more results. Now, in the next few slides, I am going to discuss about the applicability of these results to the general patients that we see in our practice. Now,
first question to all the panelists is that can we apply these results to Asian patients? Because as you see here, most of the patients that were included were white and black. So because the trial was primarily done in US and Europe, Asian patients, very few were included. So can you extrapolate this data to Asian patients? Does anybody have any reservation with this?
We can absolutely extrapolate because this is lymphoma.
Yeah. In our practice, we extrapolate these results, but still our data is also needed.
All right. So one point that I would like to make here is that from the solid tumor data, actually, there is a geographic heterogeneity in the outcomes of patients receiving immune checkpoint inhibitors for solid tumors. Of course, this is not for hematological malignancies, but the solid tumor experience tells us that patients in North America, they respond better to immunotherapy to Europeans, and Asians tend to respond less actually. So between North American and Asian, there is some difference in the response rate. This is from a meta-analysis that has been published. And of course, this is kind of thought-provoking. We do not know, we cannot really apply, but this is something to think about whether we should kind of do this kind of study in an Asian setting. Obviously, nobody is going to do that, but something to think about. Now, are the results generalizable? Like, because as you know that there were different set groups of patients here across the board. So will you like to use this regimen across the board from an age group of 12 years to beyond? Anybody would like to use BV-AVD in a different age group population?
No.
No.
Can use the
All right.
data.
So if you look at the differences in the progression-free survival, actually the major difference was noted in the pediatric age group, 12 to 17 years of age, the difference was 95 versus 83%. Similarly, in the elderly population, 88% versus 65%. But if you look at the age group between 18 to 60 years of age, there is not much of a difference between the two arms. Again, if you look at the forest plot, the hazard ratio was 0.6 for this group of patients between 18 to 60 years of age. But then, anybody would like to comment? I don't know. Any comments? Hemant sir, what's your view?
So I would have actually no hesitation in using the Nivo regime for my TYA patients and for my elderly patients. It will still have to be, approved by the US FDA, and that approval will then trickle on to the DCGI that, okay, this regime is approved in the first line, and then only we'll be able to get that, the PAP for the patient. So if I have an economically compromised patient who is 30 or 40 years of age, I would be happy to use either of the two regimes. But for the TYA patient and for the elderly patient, I think this would be the Nivo regime would be my regime of choice.
All right.
But in the subgroup analysis, even for it is stratified for age, and even in 18 to 60 groups also, it is statistically significant benefit was there. Even though the benefit is lesser, but the benefit is looks like statistically significant in terms of
actually the hazard ratio are still favoring Nivo-AVD, as I mentioned. But again, this is something, means in general, if you look at the overall effect, the effect seems to be drawn more from these two extremes of age, and the difference in the two between the 18 to 60 years of age doesn't seem to be much. But of course, as I said, still Nivo-AVD is a preferred regimen. Does gender have any impact on the efficacy? Would you like to use it differently between a male and a female patient?
No.
So these are the forest plots from the BRICAD study, HD21 study. Actually, with BRICAD, the females tend to do better as compared to males. And the German Hodgkin's lymphoma group have actually done a comprehensive analysis of their trials. And what they have shown is that female patients tend to show greater benefit than male patients in terms of treatment-related morbidity and progression-free survival. Again, in case if you have a patient who has severe hypothyroidism, would you like to use this regimen as compared to the Nivo-AVD? Or you will not let this influence your decision?
No, should not let this influence this decision.
All right. Okay. Quickly, as Amish mentioned, he mentioned about the inclusion criteria. But of course, this trial excluded several patients, those who had solid organ transplant, those who undergone allogenic BMT, those patients who had comorbidities like renal failure, cardiac failure, ILD, neuropathy, autoimmune diseases. What would be a regimen of choice in this group of patients?
Actually, these patients are excluded in all other clinical trials also. These patients represent an unmet need. So what we are practicing in a clinical practice is basing on this patient comorbidities, we will be using, we will be changing the regimens according to their comorbidities. But I don't think there will be a standard regimen for these patients. So it is basing on the patient.
But will you be comfortable in using BV-AVD in this group of patients? Because immunotherapy, say for example, somebody
there are few there are few who have been excluded in both the arms. I mean, even BV is contraindicated because
BV
it is
also
exclusion.
contraindicated in most of these.
So exclusion for both the arms. So it combines both immunotherapy contraindication as well as BV contraindication. But there is no doubt that
one subgroup we can use Nivo-AVD, which this study has also used, is HIV positive patients. Maybe we have to see what is the HIV treatment they have received. So I think few patients are having an HIV positive in this study.
That's right. Actually, that's right. Very valid point, Teja. So I think those patients who are HIV positive, they have included in this trial, and they can actually they can benefit from this regimen. If somebody has an autoimmune disease, actually, will you be comfortable in using BV-AVD?
Probably for these kind of patients, see, though there is no trial will come, what kind of the best regimen. Probably there are some of the trials where they have sequenced the therapies. They have given like brentuximab initially or like nivolumab initially, then followed by AVD kind of thing. That could be probably we can actually think about it. But predominantly, majorly, we were worried because of toxicities in these patients because of the frail in nature.
All right. So I'll skip this. So would anybody like to use this regimen, the nivolumab AVD, in children who are less than 12 years of age?
Until now, since there is no data, probably I think we should not.
No. Anybody has a different opinion? Okay, so
No,
everyone
not
would.
really.
Okay, so what regimen would you use in children who are less than 12 years of age?
I use personally like for the less than 12 years of age, either COPDAC for the male children or ABV COP for the female children. That's what we do. ABVD.
So there is a brentuximab based regimen also
Yes.
published for pediatric age group, and that has shown better PFS as compared to the non-brentuximab based this thing. And there is an AOHD trial also. So I think probably a brentuximab based regimen would be preferred in this population. Will anybody like to extrapolate the results of this trial to the use of pembrolizumab?
The problem with Pembro is it's a 3-weekly regimen. So how do we fit that in?
Right. So there is a published study of APVD actually. This has been published in Blood. This is a phase 2 study actually. And this APVD regimen given for 2 cycles and then PEG2 and then up to 4 cycles. And this has also shown very impressive results with a 2-year PFS of 97%. So, but of course, this is a phase 2 study. As of now, we don't have a phase 3 study supporting pembrolizumab.
It is in early stage, I think, no?
This has actually, yes. So one drawback of this study was that this has any stage. So this was not necessarily stage 3, stage 4. I think about some around 40-50% of the patients were the stage 3, stage 4. The rest were early stage. So yes, you're right. Actually, this was all groups. Now, now opinion from all the panelists. Will this lead to the elimination of a combined modality therapy in Hodgkin's? What is the view? Is radiation is going to be obsolete?
In early stage bulky disease, I still need to see more evidence to rule out radiation. I mean, Hodgkin's lymphoma is an extremely curable cancer. So before we come with such dogmatic statements, we will probably need more data, sir.
All right. Anybody has a different comment to make?
So
sir,
early stage,
early stage
early stage RT still has a role for now.
Yes.
And in late advanced stages, this controversy is ongoing for long. In pediatric patients already in the treatment, PET has been looking, I mean, promising for disease NFRT. So
Although,
I think, all right.
yes.
Yeah, in
One-
advanced stage, it's promising. And in early stage, definitely there is a need for more data, because at this point of time, we cannot omit radiation for the early stage Hodgkin's lymphoma.
So one important point to note here is that in this trial, radiation was allowed only to 2 nodal sites. If there was a radiation given then beyond 3 nodal sites, then that was considered as a protocol violation, and that patient was actually excluded from the analysis. So an important point to remember. I think I'll skip this question in the interest of time. How will you treat stage 2 bulky? Because this some of the trials have included stage 2 bulky also. This trial, both the BV-AVD and the nivolumab AVD arms, they have included only stage 3, stage 4, whereas some of the advanced stage trials they have included stage 2 bulky also. So the question is that would you like to use this regimen those who are in stage 2B bulky also?
Absolutely. Yes.
Definitely, sir.
Everyone
Yeah,
agrees?
these are unfavorable patients.
Yeah, unfavorable
Definitely,
risk. Mostly we are treating
Alright.
less than advanced disease only.
Unfavorable would want to use, but still not clear on whether to give radiation or not in this.
So one catch is I had to I'm eagerly waiting for the subset group of that bulky disease in this Nivo AVD, how they have performed, because nearly 30% of the patients are having a bulky disease. So I think that bulky disease data is not yet out.
Yes, that is not yet out. That's right. Now, Hemant sir, what is your opinion? Is PET-based adaptation a thing of the past with this regimen? Is it the death knell for use of PET-CT in the Hodgkin's interim PET?
So I think if you are using a checkpoint inhibitor as your first line regime, then you need to reevaluate and reassess the post 2 cycle interim PET, because you will never be able to know whether the increased metabolic activity, the higher SUV score, is because of the immune cells which are gathering there because of your treatment, or it is because of suboptimal response. But if you're using standard chemotherapy regimes like the BV, AVD, then of course it still remains important. If your interim PET is positive, then you are really truly dealing with a bad subset of patients who might need really aggressive treatment like auto transplant.
But are you comfortable in not doing the PET-CT at all, or you would do it but not act on it?
So if I were using a Nivo-based regime as my first line, then I would not think of the interim PET scan. Then I would be happy to do it after I finish my 6 cycles, because that will help me decide which site to consider for radiation. And as per the present data, there'll be very few patients who would qualify for radiation, but post completing treatment, I would not do in the interim.
Okay. All right. So I think these are the rationale actually that they had was that because there were a lot of high false positive rates in the PET-CT, and as they mentioned, they showed that although those patients who were initially PET positive at 2 cycles, later on they actually did quite all right. Whereas the end of therapy, this was again drawn from the CheckMate 205 cohort D, where they showed that the better differentiator was with the end of therapy PET as compared to the interim PET. And maybe that's the reason they decided to omit that.
Ashish,
Are
can I request you to
yeah,
wind up?
yeah. So I think 5 minutes, Amish, last question only actually. So
2 minutes.
would anybody like to use ctDNA for monitoring of the disease course?
Not yet.
Not in my clinical practice. Maybe in a clinical trial, maybe ctDNA can be used.
All right. So I think a lot of molecular alterations have been identified in the ctDNA in patients with Hodgkin's lymphoma. And this is a study published in Nature actually, where they have shown correlation between the pre-treatment ctDNA and at C1 day 15 and C3 D1. And as you can see here, those patients who were ctDNA negative at C1 day 15 and C3D1, their outcomes were excellent as compared to those patients who were ctDNA positive at this point of time. So this current study also is going to publish the data about ctDNA in the times to come. So we should look forward to it. But probably this is the future, that we would have a combination of probably PET scan and a ctDNA in the decision making to decide about whether to escalate or de-escalate the therapy. Of course, there are other prognostic markers that are being looked at: expression of PDL1, then expression of molecular MHC1, MHC2 as prognostic markers, gene expression profiling. So a lot of research is being currently done. One last question, maybe anybody can take. If a patient on Nivo AVD arm develops an immune-related adverse event, how will you treat this patient? You would switch to BV AVD or you will continue with BV AVD alone?
Tough one. Maybe switch to BV-AVD, especially given that it is unfavorable 3-4 advanced disease. Maybe switch to BV-AVD.
AVD alone.
Maybe PET will tell us if
Yeah,
it is
basing on the
CR, I would
severity of
continue
the
with AVD only.
Yeah, basing on the severity of the IRA. So if you are able to manage with, there are less severe one, maybe like with supportive treatment, and then once they recover, maybe we can continue Nivo AVD. But if it is very severe, then I think continuing on AVD or change to BV AVD.
All right. So thank you everyone for your comments and insight. So this is my concluding slide. Despite all the discussion that we have had, no question that nivolumab AVD gives better PFS and EFS. There were fewer treatment discontinuations, fewer deaths, very low incidence of immune-related adverse events, and of course, the better results, impressive results in elderly patients. For BV-AVD, the only solace is that it gives a comparable PFS, particularly with the BRICAD regimen. The results are more mature, and the use of BRICAD regimen allows a PET adapted therapy where you can actually stop the treatment at 4 cycles if the PET2 is negative. So this is one benefit of the BRICAD. So something that we will have to discuss with the patients. But problems with brentuximab have already been discussed. So with this, I think we will hand it over to Amish. Thank you everyone for your really expert comments, and particularly thankful to Hemant Malhotra sir for his valuable insights in today's discussion. Thank you everyone.
Thank you, Ashish. Wonderfully conducted panel. Really enjoyed myself. Learned a lot. Thank you very much.
Thank you, Ashish. And before I hand over mic to our expert today, Dr. Purush Parikh sir, I must say this, Ashish, that this was amazing, insightful slides what you have made. And this required hours and hours of studying, I must say that. And this also tells me, as Hemant sir earlier said in the beginning before we started, मेरे जैसा आदमी जैसा चीख चीख के चिल्ला के बोलता है, still doesn't make so much of impact. What your data full of slides have made so much of an impact, Ashish. And thank you so much for such a wonderful this thing. Just last point, what you asked about IRAE, there was only 9% of patients in Nivo AVD who had to discontinue nivolumab in this particular trial, and still that has not made any difference in the overall outcome of the results. So very difficult for me to say that whether I will immediately switch to BV-AVD till we have any other data point beyond that. But thank you so much, Ashish. Again, I salute you for such a wonderful, insightful discussion. Will not forget this for many long months to come. Over to Parikh sir. Sorry for that.
Thank you very much, everybody. I think, Ashish, I should share with you the comments that our colleagues have put on WhatsApp group, because they were not able to put on the chat here. So Prasad said that Ashish has started with the first slide, which is a googly. And that has set the tone correctly for the discussions. And then Ghanshyam echoed that sentiment, and finally the statement was made that the discussion in this panel has been so insightful that everybody now knows that if there is a Hodgkin's disease patient, they should be sent to one of the panelists here. So all the 8 of you who are here, heartiest congratulations for doing such a fantastic job. Amish said that I will give the expert concluding remarks, but there's nothing left for me to conclude here. Hemant did the job right away in his interview, and then Ashish has, really dissected not only the main publication, but also the appendix. And in fact, the slide that he showed about the survival difference between the various groups is very insightful. And I will be using that slide in my presentation very soon. There is the Asian Oncology Society conference in Xi'an, China, where I have to talk on geriatric oncology. And Ashish, thank you. I will use your slide on that in my presentation as well.
Definitely.
So with that, I would like to conclude and thank each and every one of you, but not before reminding you that our next OBTO will be on the second Tuesday of December, and hope to see you there at that time. So thank you, good night, and over to Amish for the final word.
Thank you, sir. As I said, very, I learned a lot. And thank you so much, everyone. Parikh sir, I echo Parikh sir's every word. And with that, I thank everyone. And good night to everyone. And see you second Tuesday of every month for OBTO. Thank you so much.
Good night. Good night.
Thank you and
Thank
good
you.
night.
Good night. Thank you.